Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now let's get started. Today we're going to dive into the scientific publication with the title Contribution of Bone Scintigraphy in Benign Bone Pathology. Illustrations of cases from the Nuclear Medicine Department at the University Hospital of Fez. By Asha Sidoki, Sofia Schkicker, Kpekbu Mgudira, and Nadia Ismaili Aloui. Introduction. Bone scintigraphy is the diagnostic test most frequently performed in single-photon nuclear medicine. It is one of several diagnostic algorithms whose characteristics have long been well known for the various pathologies in which it is used. Analysis of planar bone scans focuses on the appearance, number, and location of fixation anomalies. SPECT-CD locates and specifies fixation anomalies and correlates them with morphological lesions that may be suggestive of a given pathology. Subsequent morphological investigations, 18-fluorodeoxyglucose positron emission tomography, serology, bacterial cultures, or osteomedullary biopsy may be required to diagnose and assess the condition. Principle of bone scintigraphy. This isotopic imaging test, which is widely used in current practice, enables the metabolism of all bone segments to be analyzed. It involves the intravenous administration of an osteotropic radiotracer, consisting of a vector and a radioisotope, most commonly methylene diphosphonate, which was evaluated and marketed in the mid-1970s, and which binds to the skeleton in proportion to local blood flow and bone remodeling activity. Detection of the gamma photons emitted by a scintillation camera or gamma camera provides a representation of the spatial distribution of radioactivity. The main benefit of the test. It lies in the early onset and intensity of the metabolic changes detectable by bone scintigraphy, often several weeks before any radiological image appears. It also lies in the fact that the examination explores the entire skeleton at a relatively modest dosimetric cost. The benefits of SPECT-CD complementation. This functional imaging technique enables topographical diagnosis, quantification, and monitoring of bone lesions. It is a reproducible and highly sensitive examination that enables the entire skeleton to be analyzed in a single session. However, the specificity of planar bone scintigraphy remains poor for diagnosing certain areas of radiotracer hyperuptake, particularly in the axial skeleton. Bone scintigraphy may show hyperfixation in the case of osteocondensing lesions or hypofixation in the case of pure lytic lesions with no edematose reaction. Normal fixation is reassuring in principle, but may also correspond to small lesions. Spinal, pelvic, and cranial locations are better analyzed by hybrid SPECT-CD imaging, which allows precise anatomical location of lesions and improved specificity, helping to reduce the proportion of indeterminate bone scintigraphy results and reducing the need for further radiological investigations. In fact, numerous studies have demonstrated the diagnostic benefit of SPECT-CD compared with SPECT alone and planar scintigraphy for characterizing bone lesions in the combination of rheumatological and oncological indications when these lesions are undetermined. Methodology of bone scintigraphy. The radiopharmaceutical. Physical characteristics of the radionuclide. Technetium-99 meters has a half-life of 6 hours and decays by isomeric transition into technetium-99, emitting gamma radiation with a characteristic energy of 140 keV, which makes it easy to detect. Technetium-99 meters is industrially produced by the molybdenum-99 isotope in molybdenum or technetium generators at nuclear reactors. Characteristics of the vector molecules used. The carrier molecule belongs to the family of biphosphonates, characterized by a PCP chain. Depending on the possible substitutions on the central carbon atom, there are several molecules that can be used in bone scintigraphy. Methylene diphosphonate, ethylene hydroxydiphosphonate, hydroxymethylene diphosphonate, dicarboxypropane diphosphonate, available as radiolabeled single doses from radiopharmaceutical distributors or as commercial radiolabeling kits. The kits are supplied in a vial containing the bisphosphonate, a stannous reducing agent, and other excipients in powder form, ready for labeling. Pharmacokinetics. After intravenous administration, technetium oxygenate is rapidly distributed into the extracellular space. Plasma clearance of DP is bi-exponential, linked to bone uptake and urinary elimination of the radiopharmaceutical. Bone uptake is almost immediate and progresses rapidly. 30 minutes after injection, 10% of the injected activity is still present in the bloodstream. This value decreases to 5%, 3%, 1,5%, and 1% respectively within 1, 2, 3, and 4 hours after injection. 4 hours after injection. 60% of the quantity injected is fixed on the skeleton. 34% is eliminated in the urine. 6% remains in circulation. Elimination occurs via the urine. Approximately 30% of the administered activity is eliminated within the first hour, 48% within 2 hours, and 60% within 6 hours. Fastening mechanisms. The injected DP are adsorbed onto the surface of the hydroxyapatite crystals, depending on blood flow and local osteoblastic activity. Preparation of the radiotracer. Vials containing sterile, pyrogen-free lyophilizate are ready for technetium-99 meters labeling. Preparation is carried out in accordance with the manufacturer's recommendations. Shelf life. Estimated at 1 year at 8 hours after marking for the product marked at laboratory temperature. Special storage precautions. The kit and the marked product should be stored in a refrigerator and used until the expiry date of the batch. Radiopharmaceuticals must be stored in accordance with national regulations relating to radioactive products. Scintigraphic examination. Information required for a quality review. 1. Reason for examination. 2. History of bone or joint pathology. 3. Symptoms and clinical data. 4. Results of laboratory tests and any imaging tests. 5. Treatment likely to alter scintigraphy results. 6. History of kidney or urinary tract disease. The patient. No special preparation of the patient, apart from the usual precautions applied for any irradiating examination in women during the period of genital activity. There is no need for fasting. Good hydration. Emptying the bladder immediately before taking late images. Hyperdiuresis will accelerate the elimination of circulating activity, improving the signal-to-noise ratio and reducing bladder and peribladder irradiation, particularly in the ovaries. Injected activity. Peripheral IV injection, outside the site of interest, under the gamma camera if the early protocol is indicated. A 5 to 20 millicurie or 555 to 740 megabecquerel for a weight of 70 kilogram. B, in children 8 megabecquerel per kilogram with a minimum dose of 20 megabecquerel. It should be noted that in certain special cases, the injected activity may exceed the recommended limits, but it should remain as close as possible to the recommended limits. The scan speed and the time between injection and acquisition can also be adjusted to optimize images. Acquisition. Multiple phase bone scintigraphy has been performed for many years, initially on localized osteoarticular or musculoskeletal lesions, in order to increase the reliability of bone scintigraphy. Multiphase bone scintigraphy was initially used to detect osteomyelitis, particularly in children, inflammatory joint and bone pathologies, postoperative status, and acute fractures. It is now possible, with all the multi-detector gamma cameras available on the market, to easily obtain bone scintigraphy three-phase pan-corporeal. Obtaining bone scintigraphy three-phase pan-corporeal can be useful in pathologies potentially affecting more than one bone or joint, helping to improve the reliability of SO and its ability to characterize lesions. Examination protocol. Angiographic time. Immediate recording of a series of images representing the arrival of the tracer in the pathological region to be explored. Tissue time. Static images of the regions to be explored during the tracer diffusion phase in the tissue, acquired between 0 and 10 minutes after injection of the tracer when it has not yet attached itself significantly to the bone. Moan time. Images after 2 to 4 hours post-injection, whole body scan plus or minus tomography, bone tomoscintigraphy. Pinpoints the location of abnormal images and boosts contrast. Matrices of 64 times 64 times 16 or more. Consists of 64 or more images, recorded in a circular or elliptical orbit of 360-degree patients in decubitus or 180-degree patients in procubitus for analysis of the spine, each image lasting between 10 and 40 seconds. A pinhole collimator. High resolution for small areas acquisition involves 50 to 100,000 shots per image. Localized acquisition under various impacts. Useful for specifying topography, extension, and helping to diagnose the nature of abnormal images. Frontal, profile, oblique, special, flexion, extension, and rotation incidences can be performed on various joints. Multiple incidences, particularly oblique or caudal, over the pelvis when bladder activity impedes visualization. Views can be repeated later, immediately after making the patient urinate again, in some cases after urinary catheterization. Image processing. Planar images do not require any special processing. It should be noted that careful viewing of the digital images acquired by today's computerized cameras enables the full range of contrasts to be explored and greatly improves the diagnostic value of the examination. A linear grayscale contrast scale is used, with reproduction on film or on paper in video mode. The tomographic images must be processed, and the images reconstructed using filtered back projection or, better still, an iterative method. Scintigraphic semiology. Normal scintigraphy. The interpretation of a bone scan is based on the fundamental principle of symmetry, with a comparative study of the bone parts. In adults, the images show areas of more marked fixation due to their metabolic activity, their thickness, or their close proximity to the detection system. On the anterior surface, facial mass, sternum, humeral heads, anterior costal arches, and iliac crests. On the posterior surface, the tips of the shoulder blades, the posterior costal arches, the spine, and the sacroiliac joints. In children and adolescents, bone scintigraphy is characterized by hyperactivity of the fertile metaphysis, in particular the upper ends of the humeri and tibias, the lower ends of the femurs, and to a lesser extent the ankles and wrists. In the elderly, fixation is generally reduced due to physiological osteopenia. B. Anomalies and interpretation. Two fixation abnormalities have been described: hyperfixation and hypofixation. Hyperfixation is the most frequent abnormality and is characterized by 1. Intensity. Very intense, moderate, or low. 2. Homogeneity or heterogeneity. 3. Appearance, shape, and clear or irregular boundaries. Bone scintigraphy is a sensitive but nonspecific test, with many pathologies producing hyperfixations that do not allow the etiology to be determined. A single scintigraphic anomaly is always difficult to interpret and must be taken into account in the clinical and radiological context. The scintigraphic images regress over long periods, reflecting the slowness of the bone remodeling process, which takes place over several months. It is therefore usually unnecessary to repeat the scintigraphic examination before 4 to 6 months. C. Artifacts and sources of error. Radiation attenuated by metal parts or patient movement. Extravasation of RP during intravenous injection. Radioactivity of urine in cases of dilatation, stasis, or malposition of the urinary tract, particularly after urological surgery, or contamination during urination. Soft tissue hyperfixation may occur in cases of myositis ossificans, calcified hematoma, tissue necrosis, or tumor necrosis. Some bone tumors may be purely lytic and not very visible on scintigraphy when they are small. Dosimetry. The dose delivered to the body for a bone scan is of the order of milligray and is often considered to be equal to 1/10 of the dose delivered by a standard radiological examination and 1/100th of that delivered by an IVU. Whole body. 2.7 milligray per megabecquerel. Skeleton, 11.1 to 12.5 milligray per megabecquerel. BM, 5.4 to 8.9 milligray per megabecquerel. Bladder, 37 milligray per megabecquerel. Ovaries, 3.5 milligray per megabecquerel. Conduct of the examination in the Nuclear Medicine Department of the Hassan II University Hospital in Fez. In the first few minutes following intravenous injection of the radiopharmaceutical, a so-called early image is produced. At this stage, contrast depends on local vascularization. Areas of bone remodeling appear hypervascularized. Some soft tissue infections may be visible at this stage. This is followed by a delay of at least 1.5 hours to allow the radiopharmaceutical to bind to the bone tissue. The patient is therefore encouraged to drink to quickly eliminate the urinary activity. After the incompressible fixation time, the images, known as bone time, are taken. For children, ideally the parents should always be present to ensure that the child does not sleep, so that the child can have a nap during the examination. The presence of the parents, gentle restraint, the kindness of the manipulators, and the use of distractions such as a DVD player make it easier to take the images. The entire skeleton is examined, which is invaluable in cases where the location of the pain is imprecise. Infants, disabled children, etc. This is done either by scanning the skeleton over a period of 20 minutes, or in the case of the youngest patients, by localized images, each lasting 5 minutes. This procedure can be interrupted and repeated as often as necessary, with no impact on the radiation dose received, to obtain clear images, with the possibility of pauses between two images. These planar images are supplemented if necessary by tomographic acquisitions, if the child is calm, or images enlarged using the pinhole collimator. Examples of bone scintigraphic examinations obtained in 3 pancorporeal phases carried out in the Nuclear Medicine Department of the Hassan II University Hospital in Fez. Clinical case number 1. Septic pseudarthrosis. 29-year-old female patient, followed for a post-traumatic comminuted fracture of the left femur, initially treated for osteosynthesis with a screw plate removed after a local infection, followed by an external fixator. TAP scan. Consolidation of the fracture site on the left femoral shaft still ongoing, slightly more advanced than on the previous scan, with no evidence of an intraosseous or soft tissue abscess. Bone scan ordered on suspicion of septic pseudarthrosis. In the early stages, hyperhemic focus at tissue and vascular time opposite the upper middle third junction of the left femoral diaphysis. At late stage, an additional SPECT CT. A focus of bone hyperfixation involving the femoral shaft opposite the junction of the upper third and middle third of the left femoral shaft, related to an infection. Heterogeneity of the fixation in relation to the left femoral shaft, related to the ongoing consolidation process. A focus of hyperfixation opposite the first plug of the upper end of the external fixator, related to a reactive osteoblastic reaction. Scintigraphic appearance suggestive of septic pseudarthrosis, with individualization of an infectious focus opposite the junction of the upper third and middle third of the left femoral shaft. Clinical case number 2. Primary osteochondritis. 10-year-old child with a pyretic left-sided limp for 1 year. CT scan of the pelvis, showing an osteolytic image of the left acetabulum opposite the coxofemoral joint with infiltration of the soft tissues and a small amount of joint effusion related to an infection or tumor. A bone scan was ordered to establish the diagnosis. Early stage showing no asymmetry in perfusion or tissue uptake of the osteotropic radiotracer in the coxofemoral projection. Pinhole. Intense, linear hyperfixation opposite the epiphysis of the left femoral head, which appears to have lost its sphericity, extending towards the epiphyseal core. Whole body. Strengthening of left acetabular and trochanteric fixation with a reaction-like appearance and fairly homogeneous and symmetrical distribution of the radiopharmaceutical over the rest of the skeleton. Scintigraphic appearance suggestive of primary osteochondritis at stage 3B of Conway's classification. Clinical case number 3. Multiple brown tumors. 46-year-old patient on chronic hemodialysis with hyperparathynemia at 10-fold above normal levels. The diagnostic CT scan showed osteolytic lesions involving the right sacral fin and the left sixth rib, including the right sacral fin with epidural and sacral foramen extension. Bone scan. In the early stages, frank hyperemia in the right sacral projection. Late period. Large focus of very intense hyperfixation opposite the sacrum in relation to the locating CT sections with a lytic lesion involving the entire right sacral fin with lysis of the cortical bone. Focus of hyperfixation in the middle arch of the sixth left rib corresponding to a blowing lytic lesion. Discrete hyperactive focus of the distal end of the right femur corresponding to an enchondroma. Bone scintigraphy combined with SPECT CT revealed multiple brown tumors, particularly over the sixth left rib and the right sacral fin, given the patient's clinical context. Management was completed by a bone biopsy, which showed an immature bone regenerative reaction with no tumor lesion within the limits of the cores examined. Clinical case number 4. Osteoblastoma. 11-year-old boy presenting with pelvic pain without lameness and painless palpation and mobilization on clinical examination. Bone scintigraphy. Early stage. Tissue hyperuptake of radiotracer in the left hip. Late stage. Intense hyperfixation of the bone opposite the left ischiopubic ramus, corresponding to a well-limited osteolytic blowing lesion surrounded by peripheral osteocondensation with local cortical rupture. In addition, there was no clearly identifiable bone fixation anomaly on the rest of the skeleton explored. Bone scintigraphy combined with SPECT CT revealed osteoblastoma. Clinical case number 5. Active neurogenic para-osteoarthropathy. A 10-year-old child with a history of hospitalization in intensive care for management of a polytrauma. whose evolution was marked by the development of a neurogenic para-osteoarthropathic syndrome involving both hips and the right knee. Bone scintigraphy. Early stage. Accumulation of radiotracer in the right hip, knee, and ankle. Late stage. Hyperfixation of both hips, right knee, and ankle. There were no clearly identifiable bone fixation abnormalities on the rest of the skeleton explored. The scintigraphic configuration of the two right hips, knee, and ankle is in favor of an active neurogenic para-osteoarthropathy. Clinical case number 6. Unifocal Langerhansian histiocytosis. A 15-year-old adolescent presented with left hip pain. X-rays of the pelvis and MRI of the hip revealed a geotic lacunar image of the left greater trochanter, followed by a benign tumor lesion of the left greater trochanter with a perilesional inflammatory reaction. Bone scan. In the early stages, discrete hyperemia over the left hip. Late stage. Asymmetric bone fixation in relation to both hips at the expense of the left side, complemented by SPECT-CT scans, which reveal the bony lesion of the left greater trochanter described on the X-ray, which is a lacunar lesion with blurred contours and no hypertrophy of the soft tissues in relation to it. Bone scintigraphy coupled with SPECT-CT revealed that the bone lesion described opposite the left greater trochanter on morphological examinations was probably in favor of unifocal Langerhansian histiocytosis. After undergoing a bone biopsy following a bone scan, the suspected diagnosis was confirmed through histological and immunohistochemical examinations. Clinical case number 7. Osteogenesis imperfecta type 4. Patient aged 40 of short stature with a history of spontaneous fracture of the right femur. Fibrous dysplasia of the right arm is suspected. Osteolytic lesion without osteosclerosis on the right femoral shaft. Arm, no abnormalities. A bone scan was ordered. In the early stages, no abnormal perfusion or uptake of the radiotracer. At the late stage, linear hyperfixation opposite the upper third of the left femur in relation to the patient's history of trauma. In addition, there are a number of objective deformations, an arcuate curvature of the long bones of upper and lower limbs, with local thinning of the cortical bone, a heterogeneous, enlarged appearance of the sternum, straightness of the spine, bilateral renal lithiasis. Scintigraphic appearance primarily suggestive of osteogenesis imperfecta type 4, according to the Sillence and Glorio classification. Clinical case number 8. Unifocal osteoarthritis. Suspicion of polyarthritis in a 9-year-old boy with a history of septic arthritis of the ankles and hip who underwent surgical drainage. Presently has a painful swelling of the left ankle with fever. Bone scan. In the early stage, asymmetry in radiotracer uptake and perfusion in relation to the two ankles, more marked on the left. In the late period, a strengthening of the bone fixation around the left ankle. On the rest of the skeleton, there was no clearly identifiable bone fixation anomaly. Scintigraphy in favor of unifocal osteoarthritis of the left ankle. Clinical case number 9. Polyostotic fibrous bone dysplasia. Suspicion of fibrous dysplasia in a 46-year-old patient. TAP scan. Multiple lytic lesions of the axial and peripheral skeleton with a benign appearance, possibly related to polyostotic fibrous dysplasia or multiple enchondromatosis. The scintigraphic examination showed diffuse heterogeneity of bone fixation, particularly opposite the implant, and also of the anterior arch of the left K7 and the anterior and middle arch of the right K9. The sacrum and iliac bones of the left iliopubic and ischiopubic branches, both femurs and both tibias, scintigraphic appearance in favor of polyostotic fibrous bone dysplasia. Clinical case number 10. Paget's disease. A 75-year-old patient with a Gleason score of 7 and PSA equals 17.25 nanograms per milliliter for prostate adenocarcinoma. A bone scan was ordered as part of an extension assessment, which revealed intense homogeneous bone hyperfixation, particularly in the following areas: of the left hemipelvis, from the upper half of the right femur, from the whole of the left femur. Scintigraphic appearance suggestive of Paget's disease. The examination was completed by an alkaline phosphatase assay, which was found to be elevated. Clinical case number 11. Osteonecrosis of the right femoral head. 15-year-old child admitted for management of right hip dislocation with suspected necrosis of the right femoral head. The TAP scan performed 4 months before the bone scan was unremarkable. Bone scan. In the early stages, asymmetry of radiotracer uptake and perfusion in favor of the right hip. In the late phase, bone hyperfixation over the entire right femoral head with discrete heterodensity as seen on the locating CT scan. Scintigraphic appearance in favor of osteonecrosis of the right femoral head. Clinical case number 12. Osteoid osteoma. 15-year-old girl with chronic right ankle pain for 2 years. Bone scan ordered to explore the ankle and showing, in the early stages, moderately intense hyperemia on the outside of the right ankle. In the late stages, asymmetry of bone fixation between the ankles in favor of the right side, with individualization of a focus of hyperactivity projecting from the lateral malleolus. Complementary SPECT CT reveals a lacunar bone lesion with cortical thickening and nidus, suggesting an osteoid osteoma. Scientographic appearance suggestive of osteoid osteoma of the lateral malleolus of the right ankle. Clinical case number 13. Active hypercondylism. Suspicion of left hypercondylism in a 43-year-old patient. Bone scan. Early stage. Absence of asymmetry of uptake and perfusion in the two condylar regions. Late. Discrete asymmetry of bone fixation in relation to the two condyles, more marked on the left. Complementary SPECT CT reveals clear hyperfixation opposite the left condylar process with bone hypertrophy, suggesting an active disease process. Scintigraphic appearance in favor of active hypercondylism. Clinical case number 14. Renal osteodystrophy. A 48-year-old chronic hemodialysis patient presented with spinal pain for 8 months, aggravated by walking difficulties, all in an apyretic setting. A spinal MRI revealed multiple osteoporotic settlements. Bone scintigraphy showed intense and relatively homogeneous hyperfixation over the entire skeleton, more marked over the skull and facial bones, and increased fixation along the long bones, with no visualization of the urinary tract, suggesting a metabolic superscan. Focal hyperfixation of the posterior arch of the 11th left rib and the proximal end of the femurs, which may suggest bone fissures. The spinal axis shows multiple images of intense, homogeneous hyperfixation, more marked in the lumbar spine, suggestive of multiple osteoporotic settlements. The scintigraphic appearance is suggestive of renal osteodystrophy. Conclusion. In daily routine, the diagnostic process begins with clinicians identifying pertinent clinical factors and areas of uncertainty, resulting in a preliminary diagnosis. Nuclear physicians then customize the scintigraphic examination to address specific clinical concerns. It is crucial to recognize that the clinical cases provided here are illustrative examples and not absolute standards for image quality or equipment configurations. Our cases are designed to prompt individual reflection, tailored to the nuances of each individual clinical scenario. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.